Hello, this is Micah Long, and I want to expand the prior lecture on mechanical ventilation by putting the ventilator breaths together to form modes. And that's part two, which is today's topic on thinking simple mechanical ventilation. This is me. Again, I love to take challenging physiology concepts in medicine and explain it in a very simple way. My hope is that after the last lecture and today's lecture, you'll have a really broad foundation in mechanical ventilation and be able to look at vents in a detailed way and explain them in a simple way. I'm Micah Long. I'm a critical care anesthesiologist, and I occasionally blog at icudad.com. That's the types of breaths, 2.5 types of breaths, and that explains every mode of ventilation we use. Let's go through the modes of ventilation. Okay, so on a ventilator, when you're delivering a pressure-controlled breath, the vent delivers pressure, and that's fixed and set by you. It turns on fairly quickly, and you can make it turn on faster or slower by adjusting the shape of that shark fin there by adjusting the rise time. And when you fix the pressure, the flow becomes variable and reminding you that the area under the curve equals the tidal volume. You deliver that set pressure for a set amount of time when the vent comes out, and you do that on top of a PEEP and FiO2. And these breaths can be synchronized to the patient or not. Now again, V equals IR drives all of these conversations. And in this case, when the pressure is fixed, the V is fixed, and the flow is variable. And so is the tidal volume. You can change that flow by changing the pressure or by changing the compliance. Now, like I had you take in deep breaths and pay attention to the airflow over your nose, do that again, and you notice that there is a lot of flow and cold air going over your nose at the start of a breath. And as your lungs fill up with air, there's less and less airflow through your nose. That is shown here on the slide with this decelerating pattern of airflow. And you can feel it going over your nose. And that happens because of two main things. The first is that when your lungs are empty, your chest wall is closed or more small, it's ready to expand and very compliant. And as your lungs fill up all the way, your ribs start to push back on your lungs, and your lungs are stretched to capacity, and they are no longer so compliant. So the R changes as you inflate the lungs in the V equals IR equation, and the compliance goes down, so the R goes up and the flow goes down. Now similarly, when you're adding positive pressure to the lungs, at the start of a breath, before you've given anything, the lungs are filled with atmospheric pressure. And as you fill them up with air, they get filled with more and more positive pressure. And so the pressure between the vent and the lung, the delta P or V, decreases. So as you put that positive pressure in the lung, it fills up and up and up, and that delta P gets smaller. And for these two reasons, the flow decelerates quite rapidly in a pressure control mode of ventilation. That was one breath. Here's the half a breath, and it's called a pressure support breath. Pressure support breaths are synchronized to the patient. So here's the star. If a patient takes a breath, they'll pull a negative pressure and a positive flow. Positive flow meaning the air is coming from the vent to the patient. And so they trigger, the breath starts if the patient pulls enough flow into their lungs and out of the vent. And then the vent delivers a set pressure that turns on fairly quickly based on a setting that you can adjust called the rise time. But in this case, we don't pick the total inspiratory time, and the breath turns off not based on time, but based on something called flow cycling. And just a reminder here that the nomenclature of vents is that control modes refer to controlling the inspiratory time. since you don't hear control in pressure support, we are not controlling the inspiratory time. And they turn off on a set flow percent. Again, we're delivering pressure, the flow becomes variable, and what you see is that you get a decelerating flow pattern, and the vent tracks that flow pattern. It calls the peak flow 100%, or the maximum flow, and it watches it decelerate, and the moment it goes below 30% as a standard setting, the breath stops. That's called flow cycling. Cycling means how the breath turns off, and in this case it turns off based on how much flow is there. What you see in textbooks, however, is not an inflated balloon, but this more complex drawing of a peak pressure and a plateau pressure. What does that mean? Well, the pressure is sensed at the ventilator. However, the alveolar balloon is still getting inflated under that waveform. You just can't see it because the pressure sensor is right by you at the ventilator. And there's a lot of things in between the vent and the alveolus. Start at the vent, you have tubes, endotracheal tube, trachea, bronchi, bronchioles, and finally the alveolus. If there's anything in between the alveolus and the vent that is flow restricting, that means it's either small or tight, or that you've used a huge amount of flow. The vent pressure sensor will be high. Again, modes are just mixing the breaths together. So first we'll talk about traditional control ventilation, and these are either pressure breaths or flow breaths that we've talked about at a set rate. And traditional control ventilation, or CMV, conventional mechanical ventilation, does not sync to the patient. The patient can do whatever they want. The vent will keep pounding out pressure or flow breaths at a given rate that you've picked. And here you set the inspiratory pressure or tidal volume, a respiratory rate, and then based on the brand, you set either the inspiratory to expiratory ratio or the I time. And finally, you do that over a PEEP and FiO2. This picture shows you pressure control. I've circled the P because that's set by the ventilator and it looks like a square, and you get that nice decelerating waveform, and the breath is given at a set rate. I apologize, it's not perfectly accurate. Me using PowerPoint for decelerating lines is not the easiest thing in the world. Volume control's very similar. You deliver flow at a fixed rate, a Darth Vader breath. The pressure of the alveolus increases as you fill it up with air, and it taps out at a set respiratory rate no matter what the patient does. That's traditional control ventilation. We do that in the operating room all the time. The problem with control ventilation is that you can breath stack, and that means that you breathe independent of what the vent is doing. So let's take volume control. The vent again is tapping out, giving 500 ml tidal volumes every 6 seconds at whatever respiratory rate you've picked. Again, and if the patient takes a breath and they take it before that breath is due, say they take a 200 ml breath right before the vent is due to deliver a breath, the vent simply doesn't care. The patient pulls their negative pressure, they get a decelerating flow just like you and I would breathe physiologically, and then the vent says, oh, it's time to give you 500 mils, and it will give you 500 mils no matter how inflated your lungs already are, and that means that the pressure is going to go up and your volume is going to go up. Conversely, if you take a breath in pressure control before the vent is due, the vent will still give a pressure controlled breath. But in this situation, their lungs are partly filled with air, and so they're a little less compliant. They have air in their lung, and as then the vent adds air to it, the compliance goes down even more. And so they'll get a smaller vent-delivered breath, and they may even get a longer inspiratory pause. But there's nothing intrinsically damaging about this. The pressure is set by us, so you can't get barotrauma above what you've set. And they might get a little bigger tidal volume, but it's slightly limited by the compliance of the lung. Now here you may air trap and fill up the lung and have less time to breathe out, and your minute ventilation may decrease over time. But on the here and now, much less dangerous than the potential pneumothorax caused by breath stacking in a volume control mode of ventilation. Assist control, on the other hand, is the same thing except that if the patient triggers a breath, normally with a flow trigger, in other words, they've pulled enough flow from the vent into their lungs, Then the vent will give them the breath that you have set, and the clock resets. So here the vent is marching away at a set rate in a flow mode, so volume control. And now we've added assist control, and that means that if the patient triggers, they get that same breath, the flow delivered breath for a set amount of time, and then the clock resets. It's easy for a patient to hyperventilate here because they can breathe in and get 500 mils, and then breathe in and get 500 mils, and then breathe in and get 500 mils. But it's synchronous to the patient and a bit safe. And here's the same example for pressure control, where the vent delivers a pressure breath at a set rate, which you can see marching along here. And if the patient triggers, they get that exact breath that you picked, the administered pressure for a set time that you've picked, synchronous to the patient, and then the vent resets for the normal respiratory rate and I to E times that you've picked. Here's a pressure mode where they can take a breath in before they're due for one. And here what I've shown is something called double. Now let's say you do the same thing in a volume control mode of ventilation. There you are, riding the ventilator, delivering flow breaths at a set respiratory rate for a set amount of time. And you decide that before you've breathed out all the way, when you still have air in your lungs, you suck in another breath. The vent will deliver 500 mils then as well. It delivers the same breath you picked, and it does it all the time. This is a very common problem. And it's a common problem because the way we ventilate people nowadays is with low tidal volumes. So they're kind of guppy breathing. It's not how you and I normally breathe. And they're guppy breathing at a fast rate with a high PEEP. That's not very comfortable. So people want bigger breaths. Or they're acidotic because we're practicing hypercapnic respiration. We're really protecting the lungs. We're breathing barely enough. They're acidotic. Well, that's a huge trigger to breathe, and so patients want to breathe. They're septic and have metabolic acidosis. They want to breathe that acid off. And so they want big breaths, and they want them all the time. And so they may say, my 300, 400 mil tidal volume is not enough. I want more. And they'll suck in air before they have fully breathed out. And the problem with this is that you haven't breathed out your air. So if you got 500 mils the first breath, you'll get 500 mils the second breath, and you have somewhere close to 1,000 milliliter tidal volume. And it may not trigger any alarms because the vent thinks it's doing the right thing. It's just delivering a synchronous vent, which is very, very dangerous. And it's most dangerous because nobody notices it. And you're literally breathing at double the tidal volume you've picked. It's a very scary thing. Now, PRVC is a unique mode that's used broadly. And I think about PRVC as smart pressure control. It's PCAC, but instead of you picking the pressure and needing to follow the volumes closely to maintain a minute ventilation, the vent does all the volume and flow stuff for you. So the vent does one thing in PRVC, and it adjusts the IP based on the observed tidal volume. It doesn't adjust things neurally or all the other fancy things people say about PRVC. It doesn't change the compliance. It literally changes the IP until you hit a goal tidal volume. This is nice because if the patient's getting worse or tiring out, the tidal volume will go down and the vent will automatically increase the IP. On the other hand, if the patient is waking up, getting better, the vent will automatically decrease the IP. As the tidal volume goes up, as they get more compliant, the vent says, oh, I should turn that tidal volume down. Now this notably can be a problem if the patient's strong and has increased work of breathing, taking big tidal volume breaths. The vent may turn itself down, and I'll show you that in a moment. But along the bottom now you'll see the example of PRVC. You've set a respiratory rate, you've set the inspiratory time, the vent won't mess with that, and you've set a goal tidal volume of 500 milliliters. The vent picks an arbitrary inspiratory pressure of 25 and it tracks the tidal volume. Here, patient got 400. The vent says, uh-oh, 400 is less than 500, I should go up on the inspiratory pressure. So it does, it turns it up to 30. And it looks at the tidal volume and you got 550 and that says, oh, Too big, tidal volume too big, need to turn down inspiratory pressure, and it turns it down to 28 this time. And here you get a tidal volume of 500, and the vent says, oh, I'm happy. We can keep at that inspiratory pressure for now. Now, each brand of vent has a different algorithm for adjusting the inspiratory pressure, but they're all fairly straightforward, and you can watch it happen in front of you. Now, PRVC is likely not the greatest mode when you have air hunger. If you're air hungry, you can work hard enough that you are overcoming bad compliance of the lung. And when I talk about air hunger, I think of it in terms of swimming as a kid. When you dove too far under, held your breath for too long, and you get to the surface, you want a huge gasp of air. When you look at waveforms, you want this big inspiratory peak flow at the start. And you'll do that with or without a vent. You'll suck in big gasps of air. And that might be a problem for PRVC. One night at 3:30 in the morning, I was paged to cardiology. And they told me a story of this gentleman who was intubated now, who'd had a STEMI, got compressions at home by his wife, who was an EMT, and then got to the hospital, stented, and they saved his life. Wonderful thing, except now he had pulmonary edema, a little contusion from compressions, and his SAT was 90, 92, he's holding on, but he was working very hard to breathe from the irritation to the lung and the pulmonary edema. And he was a strong guy. And they said his troponin was rising, and if it rises again, they're going to bring him back to the cath lab. But he looked so uncomfortable that they hoped I could look at the vent in the meantime to see if I could get him comfortable. So I went up to the patient, and I looked at him, and he was working incredibly hard to breathe. Could see all his ribs sucking in with every breath, his belly moving out, tracheal tugging, and he was crying and covered in sweat. Looking at him, you knew exactly why. His troponin was going up. And when I took a look at the vent, I saw that the vent was in PRVC mode, and the vent was delivering no pressure for the breath. The vent had weaned itself to PEEP. Let's see how that might happen. The team set the tidal volume to 500. The vent picked an arbitrary inspiratory pressure, and the patient worked so hard they got 600 mils. And so the vent said, hey, that's too much. We need to decrease the pressure. And the patient said, I don't care, I'll still work hard, I'll get my tidal volume. And they got 590 mils, but that's still more than you picked, and the vent still says, tidal volume too high, need to turn down pressure, and so it does, and it will keep turning down the pressure until the patient is totally uncomfortable and still working hard to breathe. In other words, PRVC will wean itself in any situation if the tidal volume is higher than the goal tidal volume you've set. So when I saw that, I picked a different mode. If we are relying on the patient's compliance to generate flow, if flow is variable, that's a little tricky to do and to adjust over time as his pulmonary edema gets better. And so I picked volume control, assist control. Now, if I picked normal volume control, assist control, Darth Vader breathing has a low initial flow rate. And that's not enough for somebody that's air hungry. That would not be comfortable. And so while I will give the flow no matter what the patient does in terms of their work of breathing, they probably won't be very comfortable. And so instead I picked volume control but with decelerating flow. And that decelerating flow pattern guarantees the flow, and it guarantees that type of flow with the high initial triangle-shaped peak flow rate, no matter what the patient's work of breathing was doing. I flipped to volume control, and I watched the patient fall asleep in front of me. Their troponin came down, and they did not have to go back to the cath lab. And I felt pretty cool that by understanding ventilators, I could help somebody not get another invasive procedure. Now, SIMV modes. SIMV modes aren't that hard to understand. They're PCAC or VCAC backup. PSV modes have a backup PCAC or VCAC mode, but the moment the patient starts to trigger, from then on they only get PSV breaths that are again pressure set, triggered by the patient, and flow cycled. Again, the normal flow cycling being at 30, although you can adjust it. And there's normally a set backup rate, so if they become apneic, they'll flip back into PCAC or VCAC. But in the case that they keep breathing, they simply get the pressure support breath that you picked, on and on and on. Okay, so when I'm thinking about adjusting a ventilator, if we start at the beginning, I start with what I view as an ideal breath. I pick a lung protective tidal volume, a normal respiratory rate, an adequate PEEP, and what I view as a normal inspiratory to expiratory ratio. And then I look at it and see if it's perfect for the patient. If their compliance is very poor, like an ARDS patient, and the driving pressure is high, the pressure needed to deliver that breath, I turn down the tidal volume and I increase the respiratory rate. Then I look at the inspiratory and expiratory times and I make sure that I don't have an inspiratory pause and that I am not with a really short inspiratory time and compromising the amount of pressure to get that breath in. And then on the opposite end, I look at the expiratory times to make sure that I'm not air trapping, that the patient has enough time to breathe out with just a tiny bit of extra time in case they start to have bronchospasm later on, they're not going to air trap on the ventilator. And then once I've picked that ideal breath, I adjust the respiratory rate to all of the minute ventilation changes I need. I'm going to say that again. I start and pick an ideal breath. I pick a good tidal volume, a normal respiratory rate, and adequate PEEP, and what I view as a normal inspiratory to expiratory ratio. And then I evaluate it to make it the best for that patient. I look at lung compliance and how much pressure I'm needing to give the patient that tidal volume. And if they are very non-compliant or ARDS-like, I turn down the tidal volume and up on the respiratory rate to maintain their minute ventilation. And then I look at the inspiratory times and I make sure that I have enough inspiratory time that it's not a rapid, quick breath that needs a lot of pressure to get to an appropriate tidal volume, but that I also don't have an inspiratory pause or extra time spent in inspiration that I don't need. And I look on the flip side at expiratory times to make sure there's no air trapping and to make sure that the patient breathes out all the way with a tiny bit of extra time just in case they have some wheezing. I have a little bit of a safety margin. And then after those things, and every time I make an adjustment, I make sure the patient is synchronous. The waveform should look exactly like the pictures I've shown you, and if they don't, I try to figure out why. And finally, I'll note that in general, if you find yourself adjusting CO2 based or by adjusting the tidal volume, you're probably doing it wrong. In general, once you've picked the perfect breath, leave it be. You've picked a good one, let it be the perfect breath, and adjust your minute ventilation needs by adjusting the respiratory rate. Okay, that's the end of part 1, which is addressing ventilator breaths and the way a vent puts those breaths together to form ventilator modes. The next section will be going through some pictures of ventilator dyssynchrony, and then the final section is APRV ventilation.